Welcome to Final BTS Made Easy. We are back with another important 7-marker question from the subject of orthodontia, which is define and classify myofunctional appliances and discuss in detail about Frankel appliance. Myofunctional appliances are defined as loose-fitting or passive appliances which harness natural forces of the orofacial musculature that are transmitted to the teeth and alveolar bone through the medium of the appliance. There are various classifications. First one is based on removability. They can be removable functional appliances which can be inserted and removed by the patient. Examples are activator and Frankel appliance. Second one are fixed functional appliances. These are attached to the teeth by the orthodontist and cannot be removed by the patient. Examples are the Herbst appliance and Jasper jumper. Then semi-fixed functional appliances. These are partially removable having some fixed components. Examples are Denholz and Bass appliances. Classification by profit includes the tooth-borne passive appliances that have no intrinsic force-generating components such as springs or screws. They depend on the soft tissue stretch and muscular activity to produce the desired treatment results. Examples of tooth-borne passive appliances are activator, bionator, and Herbst appliance. Tooth-borne active appliances include modifications of activator and bionator that include expansion screws or other active components like springs to provide intrinsic force for transverse or anteroposterior changes. Third type is tissue-borne appliances. Tissue-borne appliances are mostly located in the vestibule and have little or no contact with the dentition. Examples of such an appliance includes the functional regulator of Frankel. Third classification was given by Tom Graber. He classified it into Group A, which are the teeth-supported appliances. Examples are Catalans, inclined planes, etc. Group B are the tissue or teeth-supported appliances. Example activator, bionator, etc. Group C are the vestibular positioned appliances with isolated support from tooth or tissue. Examples are oral screens, Frankel appliance, and lip bumpers. Fourth classification is based on the transmission of force. They are classified into Group 1, 2, and 3. Group 1 appliances consist of appliances that transmit the muscle force directly to the teeth for the purpose of correction of the malocclusion. Examples include oral screen and inclined planes. Group 2 appliances reposition the mandible and the resultant force is transmitted to the teeth and other structures. Examples include activator and bionator. Group 3 appliances also reposition the mandible, but their area of operation is the vestibule, outside the dental arch. Examples include Frankel appliance and vestibular screen. Based on myotonic and myodynamic principles, they can be classified as myotonic appliances, which are functional appliances that depend on the muscle mass for their action, and myodynamic appliances that depend on the muscle activity for their function. Frankel appliance, which is also known as the functional regulator or vestibular appliance, was developed by Professor Rolf Frankel. It focuses on correcting malocclusions by modifying the functional environment of the oral musculature. The appliance primarily operates in the vestibular space, isolating the teeth from abnormal muscle forces and promoting balanced craniofacial development. Frankel has based his appliance on the following principles. First is vestibular arena of operation. According to Frankel, the dentition is influenced by perioral muscle function. Abnormal perioral muscle function creates a barrier for the optimal growth of the dentoalveolar complex. Thus, the Frankel appliance is designed to hold away the buccal and labial muscles away from the dentition, so that the dentoalveolar structures are free to develop. In addition, the Frankel appliance acts as an exercise device or an oral gymnastic device that aids in correction of the abnormal perioral muscle function. Second pillar is the sagittal correction via tooth bone maxillary anchorage. The Frankel appliance is anchored firmly in the maxillary arch by means of grooves in the molar and canine regions. The mandible is positioned anteriorly by means of an acrylic pad that contacts the alveolar bone behind the lower anterior segment. This lower lingual pad acts more as a proprioceptive trigger for postural maintenance of the mandible. Third principle is differential eruption guidance. The Frankel appliance is free of the mandibular teeth. This allows selective eruption of the lower posterior teeth that aids in correction of the discrepancy in the vertical dimension and also helps in sagittal correction of class 2 malocclusion by allowing upward and forward movement of only the mandibular teeth. Fourth principle is that it has a minimal maxillary basal effect. It has been noted that in most class 2 malocclusions, the maxillary position is close to normal while the mandible is retruded. The Frankel appliance has relatively little retrusive sagittal effect on the maxilla in contrast to the marked protrusive change in the mandible. Periosteal pull by buccal shields and lip pads. The buccal shields and lip pads are extended to bring about outward periosteal pull. This aids in bone formation at the apical base. Coming to the mode of action, there are four effects of the Frankel appliance on the dentoalveolar structures. First one is the increase in the transverse and sagittal space. Frankel's appliance eliminates restrictive forces from perioral muscles promoting bone growth via periosteal pull. There is also increase in the vertical space since posterior teeth are free to erupt as the appliance does not cover them. There is also mandibular protraction as Frankel's appliance guides the mandible to a mesial position, retraining the muscles and aiding in condylar adaptation. Fourth effect is on muscle function. It corrects the abnormal muscle activity, enhancing blood circulation and muscle tone. There are 5 types of Frankel appliances. FR1 treats class 1 and class 2 division 1 malocclusions with variations like FR1A, FR1B, FR1C based on overhead severity. FR2 is commonly used for class 2 division 1 and 2 malocclusions. FR3 treats class 3 malocclusions characterized by maxillary retrusion. FR4 corrects open bites and bimaxillary protrusion. And FR5 incorporates headgear for long face patients with vertical maxillary access. The components of Frankel appliance can be divided into acrylic and wire components. Acrylic components are the buccal shields, lip pads, and lower lingual pad. Wire components are the palatal bow, labial bow, canine extensions, upper lingual wire, lingual crossover wire, support wire for lip pads, and lower lingual springs. Additional features include the lip pads, which eliminate hyperactive mentalis muscle activity and help in bone growth via periosteal pull. Buccal shields eliminate buccinator muscle force, promoting unrestricted dentoalveolar development. Palatal bow prevents dislodgement of the appliance and supra-eruption of the first permanent molars. Canine loops aid in transverse development by eliminating restrictive muscle function in the canine region, and labial and lingual bows maintain tooth positions and prevent undesirable tipping during treatment. That's it. Thank you for watching. Do like, share, and subscribe to my YouTube channel and stay tuned for further videos.